Doctors of Reddit. What is something you can assume about your patients after an examination? Story 1. I'm a neurosurgeon. Had a patient with sudden onset back pain a few days prior, who immediately got an MRI, of course, which showed a herniated disc and was referred to me for surgery. His history isn't consistent with radiculopathy, so I do a full exam and find he's got rebound tenderness in the RLQ that was radiating into his flank, hence the back pain he reported to his doctor. I call my general surgery colleague and tell him, I may be hallucinating, but I have this guy, and I think he has a hot belly, probably appendicitis, and it's been going on for 4 days. Do you think you could come down and take a look at him? Turns out I was right, and he had an appy that afternoon. Made me wonder exactly what type of exam his PCP did before sending him on. The irony is, I had a very difficult time convincing the patient it wasn't his disc, and that he had a potentially life-threatening abdominal process. He just kept telling me, but look at the report. It says I have a herniated disc. My doctor showed it to me. I didn't send him to the ER by himself because I wasn't sure he'd just skip out and leave, and I couldn't very well have security escort him, which is why I had the surgeon come down to my office, examine him, and hope he'd have better luck convincing him, rather than a thoughtless neurosurgeon who just doesn't want to operate on a patient in so much pain. Story 2. My most memorable exam was when I examined an elderly man's abdomen and discovered rebound tenderness. He had been transferred into the ICU of a hospital where I was working locum tenens, where anyone could admit patients without consult critical care. I could tell that no one had ever examined the patient because my exam was so cursory and took far less than 5 minutes. The only plan the primary attending had was to proclaim the patient to be dying, without any inkling of a diagnosis, and was going to encourage the family towards comfort care. So I ordered a CT of the abdomen and discovered that he had ischemic bowel. He went from being proclaimed dying to the OR in less than a couple of hours. Story 3. Elderly lady fall. Fall, IIRC. She had a small stroke which precipitated the fall. Knee was swollen, negative XR, couldn't walk on it, consult rehab me. Actually examined the knee. Tense, painful effusion with decreased ROM. Ligaments felt tight until posterior drawer test. No hard end stop, very spongy. Sure enough, the MRI showed big OLPCL avulsion right off the tibia. Wasn't mechanically obstructing. Dec ROM D/T the effusion. So wasn't surgical. We rehabbed her, and she went home after like 10 days or something. Another one, kinda. Middle-aged female, history of migraines. PCP started Topamax or something. Started having a few falls. Finally, her husband brought her to the ED. Workup, including head CT negative. PT saw her, and she was needing like Mod-Max assist to walk. BC, she was so ataxic. ER almost discharged her, but the PT threw a fit, and she went to OBS, and they consulted me for rehab. On exam, husband was there, and it was one of the weirdest patient interactions I'd seen in a while. Supposedly, she was completely independent previously, but she was obviously confused. Don't want to type out everything, but trouble with sequencing/multi-step commands, possible apraxia. No clear focal weakness, but diffusely ataxic. But I especially remember that she would alternate between jovial and agitation the whole exam. I asked her spouse if her personality had changed, and he said she was a totally different person over the preceding few months, chalked everything up to the Topamax. And then, she had a clearly UP going toe on the left. Something was up. Reviewed the CTH images myself and, man, that right side really looked full, hyper-attenuated vaguely in the subcortical/BG area, especially on my favorite 30/30ths window. Called RADS. They couldn't figure out how that got missed. Later MRI confirmed mass, concerning for GBM. Surgery got involved, lesion was biopsied, and unfortunately she never woke up after. Story 4. I was in my rural family med rotation. 63 YO man comes in with CC of chills. Preceptor sends me in first. I'm talking with the guy. He's pleasant, very chatty. Says 3 days ago he started getting really cold or really warm. But every time he takes his temp, no fever. He says his granddaughter has some kind of URI, and he was around her last week. He has no N/V/D, night sweats, weight loss, cough, headache. No previous HX of cancer, or FMHX. Guy's healthy as a horse. Vitals are all normal, he takes no meds. His HX only sig for diverticulosis. I do my physical and everything is normal except he has slight abd tenderness in the RLQ. The point reports it as 2/10. I report all this back to my preceptor, who then double-checks and can't find anything. We discuss and both say that only having chills is a bit weird, and something doesn't feel right about the abdoc tenderness. We decide to get blood, and the guy has a white count of 26,000. So we scan his abdomen immediately, looking for cancer originally, but the guy had a 3 centimeters abscess in his sigmoid. Immediately send him to the ER, where he started going septic, but they got it drained, and he recovered. Story 5. When I was a student, I did an overnight internal medicine rotation that was mostly admitting patients from the ER. Got a consult to admit an uncontrolled diabetic patient with concerning symptoms, fever, chills, elevated WBCs, not responding to meds. I go into the room and start talking to the patient. He speaks Spanish and his son is doing his best to interpret, so history was a little difficult. I listen to heart and lungs, palpate abdomen, nothing major. I then ask about any new or open wounds, and he says he doesn't have any. I pull the sheets back from his feet, and he's still wearing his socks and shoes in the bed. I ask if it's okay if I remove them to examine his feet, and he agrees. First shoe comes off, and I can smell the wound before I see it. I remove his sock, and sure enough, he had a huge infected wound on the bottom of one of his feet that he didn't even know was there, and no one else had bothered to look at his feet. Not sure if the language barrier came into play, but I'm sure for some people it might cause them to be less thorough. But that's where physical exam can save you. First rule of diabetes: always check the feet. Story 6. I work outpatient GI. 76 YO, new patient for change in bowels, a little stomach upset, pretty routine. Patient is roomed late. My ma says some type of hold up front. I ask front desk. We've had a lot of problems. Say patient took an unusual amount of time to fill out forms. She's sweet, oriented to person/place/time. She recalls recent and past current events. She has a 1/2 scratch on her face with bruising, and when I ask how she got it, she can't quite recall. Vitals unremarkable. Neuroexam completely intact except for maybe a mildly dilated pupil. I get my SP, he looks at her too, not impressed, but I told him something is up. Thank God he took me seriously. She has no family, lives alone, so we call EMS for eval. Called her the following week, and it was determined D. She was having mini strokes and had a grand mal while hospitalized. I can't say I knew what was going on, but I'm so happy I took the extra time to investigate, because who knows what would have happened if she was alone at home. Story 7. We deal with this in pharmacy too. Hopefully you'll indulge one long example that happens quite frequently, followed by a few less frequent ones. And TLDR, House was right. Everybody lies or tries to downplay things, sometimes even subconsciously without them realizing it. I noticed you're a bit late picking this up on time. Have you still been taking this every day? Are you having side effects or problems with it? Well, I forget a little bit sometimes, but it's not that often. Did you get any of this from another pharmacy in the last 6 months? No, only here. So you only picked up 120 pills over the last over 6 months, which is 180 days. Any idea what may be happening? Yeah, I forget to take it sometimes, it's not that bad. So, sometimes seems to mean that you are only taking it 2 out of every 3 days, or about 66% of the time. Does that maybe sound like how often you're forgetting? Oh yeah, I guess I mean my Monday, Wednesday, and Friday are very busy in the morning, so I guess I'm forgetting to take them those days a lot, because I'm so busy that I can't ever remember if I already took it or not. Okay, so let's try and figure out a solution, whether that's taking them a different time of day, or using a pill box so you can just open it and take that day's pills one time, and you'll be able to see if you already took it or not. That's a good idea. But is that going to help with the diarrhea these pills always give me? Why didn't you mention that big problem when I asked about problems originally? Starts all over, basically. See also, when did you have your last tetanus booster? Oh, a few years ago. It was actually in 2001. I see here you have medicine listed. When did you start taking that? Oh, I only took that once a long time ago. It was last month. When is your colonoscopy? I need to order this specific prep your doctor won't change from. Oh, it's not for a while. It's 3 days from now. Story 8. I remember being absolutely astounded by how much people can end up drinking. The level of alcohol that the frequent flyers of my intern year program was crazy. We had maybe like 3 to 4 patients who would be habitually readmitted for withdrawal. The numbers they reported were like truly outrageous. The saddest one was a guy who was drinking lemon, or maybe vanilla extract bottles, because he was homeless, and it was the most cost-efficient. It was something close to like 90 standard drinks a day. Would probably kill most people. Story 9. Radiologist here, and I only have one somewhat matching moment since my field is fairly objective. When I did a rotation in pediatric radiology, we had this father coming in with his kid. The kid was about 5, wouldn't eat properly, and throw up a lot, and was very slim. I read their file, and it stated that they were in and out of the hospital a lot, for the same issue over the last half year or so, but no cause was ever found. It even said the father suspected his kid might have ingested something, but since the symptoms were so unspecific, this lead was never followed. So this time it seems they must have reinforced this suspicion pretty heavily, as they came to me for a functional fluoroscopy. First picture revealed a button battery stuck in the kid's esophagus. The father was so relieved that finally something was found, his eyes teared up. I read up on the file that the battery was removed endoscopically the same day, and that there was significant inflammation of the esophagus due to leaking battery acid. Crazy to think that this dad suspected something along this line, and it still took half a year to finally being looked into properly. Second, not exactly matching story, is from when I was in the last year at university, doing clinical internships. I was at this medical ER in a bit city with a lot of homeless people, and one day, this comatose guy comes in with suspected alcohol overdose. I remember him stinking of vodka. Each time when I tried to establish peripheral vein cannula, he pulled his arms back and groaned, which resulted in me missing the shot. The 5th, 6th time trying to establish the cannula, now in one of his feet, he still pulls his legs back and I start to feel really angry. I thought, this alcoholic ass won't let me do my job properly, only to block an ER room for people who are really sick, just so he can sleep out his overdose. With the help of a few other guys, we finally got a cannula, and drew some blood as well. 30 minutes later, the lab results come back, and he had basically no alcohol in his blood whatsoever. So we did a brain CT scan, and it turns out he had a cerebral hemorrhage. This instance taught me a lot about how easy it is to misjudge people and to treat all my patients equally, even in my thoughts. Story 10. Psychiatrist here, late to the party but thought I'd share a story from my residency years in case someone happens to still see this thread. I was at the brief internment unit. Acute psychotic cases mostly. And there was this woman that had been there for some time. She had paranoid delusions about the Russian mob trying to get her, complete with hallucinations and everything. Her family had confirmed it was all made up in her head, and nobody was following her. She had been getting medication for some time, and her symptoms had improved a lot. She no longer believed she was in danger or being hunted, and everything seemed to be going well. As the procedure usually goes, the staff contacted her family so she could start going out for the weekends with them, before being fully discharged. First weekend away from the hospital, she was taken against her will due to a misunderstanding involving a debt. Adding the other comments here so everyone can see it. Happy ending though, she was found and gotten to safety quite quickly, because we had already spoken to the police about her delusions just in case, and they were quick to act when she disappeared. And yes, people got locked up and other women were found. It was, all in all, a happy/satisfying ending. Story 11. Nurse here, I tell my students this one a lot. Had a very difficult long-term dementia patient that some idiot higher-up decided was appropriate to put in a 4-patient ward on an acute care floor. So people recovering from surgery, etc. Not all dementia. This patient would scream and throw herself out of bed routinely all night. Finally got a sleeping pill ordered, and gave it 3 nights in a row as she wouldn't stop screaming about the rats climbing on her, and waking up the entire ward, and the NICU on the other side of the wall. 4th night I go in when she starts screaming, sleeping pill ready, and there's an actual mouse on the windowsill next to her. Felt like such a jerk. Now, when a delirious dementia or anesthetized patient says something off the wall, I always say, did you check though? Are you sure there aren't whatever crazy thing they are seeing? Story 12. A COVID story, unfortunately, about my opinion as a general practitioner, up against an internal medicine specialist. My grandmother was isolated for COVID, and she steadily got weaker and weaker. In my country, the hospitals were so full that some get home quarantined, and doctors give instructions via Zoom or go on home visits in bunny suits. It was such a desperate time. No vaccines had arrived yet in my third world country. Anyway, I noticed that my mother was alerting me that my grandmother's O2 SATs were going down, mid-80s, which is a bad sign she might need hospital admission and a high-flow nasal cannula. I'm just a GP, so my family found a specialist to treat her. The specialist told me I was paranoid. Your grandmother only has mild COVID. The pulse oximeter probably has a low battery. Change it and see what happens. She'll be fine. I pleaded with my family this wasn't the case. I said she was getting worse, and she could die if we ignored her symptoms. No one listened. I was deployed as a COVID swabber at this time, and I couldn't go home because I was exposed every day. But the patients I saw near death, my grandmother was starting to look like them too. So somehow, someone goes there to change the batteries. But the specialist also sends one of her colleagues for a home visit a day later. The visit reveals my grandmother had severe pneumonia, based on auscultation alone. Decreased breath sounds instead of just crackles. We found her a hospital bed in another city, 40 kilometers away from where I worked a few days later. Where we were in the capital, the beds had run out. My grandmother died 10 days later in some rural hospital away from family, just because some specialist told us she looked okay over Zoom. We can't file a case. The specialist is my cousin. Story 13. I was working as a scribe when we went to see an 8-year-old girl that had a fever. Nothing too remarkable until we started the physical exam. We examined her head. Normal. We examined her upper extremities. Normal. Then we pulled up the blanket to examine the lower extremities. Her feet were the size of an infant's. You should have seen the look on the doctor's face as he was trying to figure out how the girl's feet got so small. The mother looked up at the doctor, saw the look of confusion on his face, and said, "Those aren't her feet." She pulled up the blanket a little further, revealing a pair of perfectly healthy feet, nestled next to the feet of a doll that she put under the blanket. We saw the doll's feet and thought they were the girl's. Edit. For those wondering she had the flu, she turned out fine. Story 14. Doctor here. When I was working in the ER one evening, I had my worst experience so far. I was called to one of the examination rooms that are designated for infectious patients. This is already a bad sign as it usually involves some sort of abscess that needs to be drained. However, this time it was far worse. I was told by the nurse that it involved a man who had bilateral venous ulcers on his legs and that they were now infected. I looked through his journal and saw that he last saw a doctor about 10 months earlier and no note of any checkups after, not by a nurse or a GP. Therefore, I asked my nurse when someone last took a look at his legs. Not since his last journal entry. Then I asked when was the last time he changed his dressings on the legs. He hasn't. Some background info on the patient. Old man who lived by himself in his trailer that was parked in the middle of the forest. He had no running water. He was a bit of a drinker and a general I don't care mentality. Awesome. Suited up and went into the room. The room smelled like an odd combination of stale beer, mold, and disease. Certain infections smell different, and this one was very pungent. Almost sulfuric. I introduced myself to the patient, who didn't understand what on earth he was doing there. All he wanted was some antibiotics for a flu, and then he was sent here. Why on earth do you want to look at my legs? They were already taken care of last year. Great. So we started unfolding the dressing. They were crusty and crackled as we unwrapped the first leg. As we got deeper, it changed color to some sickly yellow, and the stench became worse and worse. One of my nurses left the room to throw up. Then I saw it. Very small, but inside a fold there was a little maggot who squirmed. When we finally got to the wound, we saw all the little maggots feasting on this man. There must have been 50 of them. The stench was absurd. I was focusing a lot to breathe through my mouth, but then it felt like I could taste, which made it even worse. My nurse came back and promptly went out again. I unwrapped his other leg, and same story there, but the infection was much deeper and I could see a few tendons on the base of the ulcer. Absolutely disgusting. We had to clean off the maggots and place them in a bowl, but they were squirming and went on the floor and crawled all over the place. I had to watch my feet so I didn't step on them. After that, we took the patient to hose him down to at least try to get rid of some of the smell. Then booked to the OR for debridement and a fresh vacuum dressing. Discharged a few days later with strict instructions and booked him in to return for redressings and checkups. Then we never heard from him again. TLDR maggots. Lots of maggots. Story 15. Lots of ED docs in certain areas don't do pelvic exams. Don't come for me. It's real in rural U.S. I saw it. Poor rural patient, with no health insurance, told to see OBGYN, PCP, whatever, diagnosed with AUB and sent home with Prevera or whatever. Patient goes again to ED, this time anemic, and gets shipped 3 hours to academic hospital. Fungating mass of cervix. Stage 3, or IV, cervical cancer. I saw it at least 3 to 4 times in residency. Do the pelvic exam. Other one. Obtunded ICU lady with pelvic mass on outside court. Family demands transfer to our center for GYNONC consult. Helicopter ride later, she is in our hospital. They rescanned her on arrival. And no mass? Ovarian cancers don't just vanish. Being the low lady on the totem pole, I'm sent to the ICU to look at this lady and get report from nursing. Foley is full of weird gunk. I point and ask nurse about it. I tried to show the team, but they seemed unimpressed. Mass gone. Foley weird. Consult urology. I think her bladder was the mass. My upper level is unimpressed by my suggestion, but the ICU resident sees my note before she can amend it. Urology writes an unprofessional note, but orders cystogram to appease. Cystogram aborted due to gross spillage of dye into her abdominal cavity from the catheter. Lots of time, a transfer, and money for urinary retention and a bladder rupture. Story 16. Have found this mass before. One that I remember was an older Chinese woman. She was blind, basically deaf, dementia, and kept being brought into the ED for incontinence and diagnosed with UTIs. When I saw her, her daughter mentioned bloody mucus in her diaper. We did the exam. Fungating mass, eroding into the bladder and bowel. She was admitted, gotten into hospice, died peacefully and comfortably at home. Story 17. Have to add another one. Patient at an FQHC came in as a walk-in for severe headache and dizziness that started approximately 20 minutes before. Saw a new grad NP, stated in the note that it was the quote, headache of his life, and was a thunderclap headache. No neuro exam documented. I later confirmed she did not know how to perform a neurological examination or that she should even had done one. Sent him out with a prescription for Tylenol. Patient sees me 2 days later. I see him coming down the hallway as the MA is rooming him. He's drifting like a ship in the wind. Has truncal ataxia, cerebellar function is all messed up on exam. Sent him to the ED. They confirmed subacute posterior stroke. Story 18. Later on he continued to work as a handyman, and he was using an angle grinder. When the cutting wheel shattered, since it didn't have a safety guard, a piece flew and hit him in the testicle, causing a massive scrotal hematoma. He came in with a scrotum the size and color of a large eggplant, walking like a cowboy down the hallway. Send them back to the ED. The urologist took care of him. Came back about 2 weeks later. He was a highly non-compliant diabetic and had poor self-care in part due to his stroke, and ended up getting an infection on his surgical site and getting Fournier's gangrene. Back to the ED. Don't know what happened to him after that as I left shortly thereafter. Story 20. I had a patient present after coughing up a cup of blood, large volume hemoptysis. He had coughed up a cup of blood suddenly every 3 to 5 years for several decades, and no one had figured out why. His CT scan showed cystic masses in his lung apices, thought to be chronic TB. On careful review of systems, he also reported mild chronic nausea with occasional vomiting and was raised in Guatemala until his teenage years, making exotic chronic infections plausible. My diagnosis, which turned out correct, was tapeworms. The worm had encysted in his lungs, and during its reproductive cycle, the cysts would break open, causing hemoptysis. We gave him ivermectin, and he hasn't been back with hemoptysis since. Story 21. I worked on a case of an elder woman living on a farm who got pinched in the leg by a chicken and tried healing with homemade ointments. Her lesion got infected, and by her 4th day in the hospital her leg was healing, but she became rigid, with neck and arms feeling like wood, unable to move. On night shift, with her attending doctor absent, I called him as her condition worsened, including stiff legs. He was surprised and gave no diagnosis. I researched, and a disliked surgeon passing by asked why I was worried. I explained and he said, "That's tetanus." I realized I missed it, and she was transferred to ICU but died hours later from this deadly, nearly untreatable condition. Story 22. When my gallbladder failed, I nearly died from body poisoning. Couldn't hold down food for a month, then water for a week, with stabbing abdominal pain, on IV fluids, strong pain medication, and anti-nausea medication. After 2 weeks of tests, blood, ultrasounds, endoscopy, colonoscopy, aita scan, performed wrong without dye, a GI specialist examined me, pressed my abdomen, causing severe pain, and said, "Your gallbladder is failing, or you have a retrocecal appendix," and they did the aita scan wrong. He had me eat, and I vomited. He confirmed gallbladder failure. The surgeon, initially skeptical, apologized post-surgery, finding it badly inflamed. The specialist explained bile leakage caused vomiting and crystallized acids, shredding my esophagus and intestines. It was a cool medical moment, with him involved for only 5 minutes total. Story 23. A patient came in with severe chest pains and shortness of breath, an older man, so I immediately thought heart attack. Normal tests were normal, but symptoms persisted, so more complex tests were considered. As a med student halfway through, I was asked to examine him. I found rashes on his back from the spine forward while listening to his lungs and told doctors he might have herpes, zoster, shingles. They confirmed, and he went home an hour later with antivirals. I wanted a cane, and to start popping pills after that. Story 25. As an internal medicine resident, I saw a healthy-appearing woman in her 60s for persistent flu. She had a dry cough for a month, with negative flu tests and a normal chest x-ray. During the exam, I felt a hard, round lymph node above her left clavicle, which she was unaware of. I ordered an ultrasound, leading to a biopsy that revealed stage 4 squamous cell lung cancer, not seen on the initial x-ray. She underwent therapy and was in remission a year later. I almost missed it by not checking lymph nodes, relying on her history. Story 26. I saw a man in his 50s with numbness and weakness in his legs, plus urination issues, after 2 months of acupuncture with no improvement. His symptoms suggested spinal cord compression, a medical emergency. Imaging showed cancer pressing on his spinal column. Despite immediate treatment, he lost the ability to walk and died months later. I assumed his delay in seeking care made it too late, wishing he had come earlier for a different prognosis. Story 28. As a med student, I interviewed a patient in the infectious diseases department, translating for a classmate. He mentioned it was Saturday, it was Friday, which I initially dismissed. My classmate insisted I ask the date. He said 2002. It was 2018. Further questioning showed all his answers were 16 years off, revealing neurosyphilis. I assumed his infection was minor, not neurological. Story 30. I performed bunion and hammer toe surgery on a woman with no known allergies. Post-op, she had excruciating pain 18 hours later, with elevated eosinophils but no infection. I asked about jewelry reactions. She recalled tongue swelling from a piercing, suggesting a nickel allergy from the hardware. After switching to titanium, her pain resolved. I assumed no allergies based on her history, nearly missing it without a residency case experience. Story 31. As an emergency radiologist, I imaged a 4-year-old boy with a rigid abdomen for months, diagnosed as constipation by his pediatrician, with no follow-up. Imaging showed his liver replaced by a mass, likely hepatoblastoma. I asked why they waited. They were satisfied with the constipation diagnosis. I assumed it was neglect, leaving follow-up to the pediatrician. Story 32. I was a third-year medical student, on a flight with my dad from Sydney to Singapore. Could any doctors on board make themselves known to the cabin crew? Responders were me, medical student, my dad, medical oncologist, treats cancer, and an orthopedic surgeon, fixes broken bones. Patient was a late middle-aged man in business. First, it was upstairs. Class who was diabetic. He had taken his insulin prior to his meal, then decided he didn't like the food. Went into hypoglycemia. When we got to him, he was pretty drowsy. Tried talking to him, tried to get him to drink some juice, no luck. Dude passed out completely, couldn't get a response. So the 3 of us dragged him out of his chair and onto the floor, in the aisle. We got the staff to get us all their medical supplies. They've actually got quite a lot of stuff. IV bags and equipment, cannulas, oxygen, emergency drugs, a bunch of stuff. On this particular plane, all of the non-bulky items were stored in plastic lunchboxes, with labels on the lids as to what was inside. The contents of the boxes were not otherwise sorted. We knew we had to get some fluid and sugar into this guy, or he might die. We'd managed to check his blood sugar with his own equipment. I can't remember the value, but it was alarmingly low. The first thing we needed was access to a vein. Once we had that, management would be straightforward. We found the box that contained the cannulas, opened it, and dumped the contents on the floor, sifting through them to find what we needed. We found plenty of cannulas, but couldn't find a tourniquet anywhere. In retrospect, I think we might have lost it under a seat, but who knows. We tried to improvise with rubber gloves tied around his arm, or just physically squeezing his arm while someone else tried the cannula. Now, keep in mind who was attending the patient. Me, a student who had only recently learned how to put in a cannula on a mannequin, and two senior doctors who had probably not put in a cannula in over 20 years. At first, we were working without the cabin lights on. It was a night flight, but after a couple of tries insisted on more light. Between us, we must have had 20 tries at getting a cannula into this guy. We were panicking and running out of cannulas. There were discarded cannulas all over the floor and rolling under passengers' chairs. No matter what we did, we just couldn't find a vein on this guy. So we started looking for alternatives. I found a vial of glucagon, essentially anti-insulin. I had no idea how to use it, so I pointed it out to my dad. He grabbed the syringe in the kit, jammed it into this guy's leg, and pushed the plunger in. Dad, I hadn't drawn up the drug yet. What was in the syringe? Air. So that was good. We were rummaging around for other tools. We found an intraosseous needle, enormous thing, used for stabbing through your shin bone directly into the marrow, and were seriously considering using it. Instead, we retrieved one of the relative clean used cannulas and kept trying. It might have been as long as half an hour of this guy comatose and us panicking on the floor. Eventually, we managed to get access. It wasn't great, but it was enough. We hooked up the IV, manually pumped fluid and dextrose into him as quickly as we could, and started to revive him. We wrote up a big long set of notes, as well as advice to the airline on how to improve their medical supplies so it didn't feel as frantic in future. We landed in Singapore a few hours later, and the guy was first off the plane and taken to hospital for a proper check. AFAIK. He was fine. Oh, and the patient was a GP, who was probably the most qualified of any of us to deal with the issue. Story 33. I'm a nurse, so naturally, my mother called me one day when she had strange symptoms. Earlier today I had this feeling like there was a squirrel running around in my belly. I reassured her that it was probably gas. It happened again a few days later when she was in the car with me. Something made me take her right to the emergency room. The doctor evaluated her, and basically accused her of making things up. I asked for a different doctor, because she is not a complainer or a drug seeker. Turns out it was a malignant brain tumor, glioblastoma, that was manifesting itself as abdominal seizures. They said she had 1 to 2 years to live. It is now 7 years since surgery, chemo, and radiation, and she is still alive. Story 34. As a resident, I had someone come to clinic to resume routine care for screenings after an older sibling had passed. Reason for visit/CC. I want to take better care of my health. I noticed they had a little bit of blood on their napkin and asked to examine their mouth, a few missing teeth, and a large mass on their gums. I immediately sent them to ENT, where they learned it was oral cancer. They eventually underwent the entire treatment plan of mandibulectomy, jaw resection, glossectomy, tongue removal, and likely neck dissection and laryngectomy. I followed them peripherally on a consulting service until they ultimately passed away in the hospital about a year later. The ironic part of the whole situation makes me reflect on the value of early detection. Just more reasons to avoid tobacco and alcohol. 80% of oral cancers attributable to their consumption, and to eat a healthy plant-based diet. Story 35. Neurologist here. A healthy patient came in with a few months, history of left-hand numbness. My first thought was carpal tunnel syndrome, but physical exam was not very convincing. I got a CT of the head and found malignant metastatic lesions. The patient and family had been talking about expensive designer bags and were very happy. I had to break the news. They went from healthy to potentially having only a few months to live. Edit. I am reading replies of people getting worried about their or their loved ones' symptoms. Remember, cancer is incredibly rare. Everything else is much more likely to be the case. Story 36. During my practical year, I was in the emergency room. A 70-something-year-old woman, lovely person, one of those candy-giving grandmas with perfectly laid curls, came in complaining of a rash. Obviously, they sent in the student, because rashes are often considered minor cases for emergency consults. Picture me, young and excited about the opportunity to practice, with much of my knowledge gained from Gray's Anatomy, which is not fully realistic. I examined her, and marked the affected area, right leg, slightly above the ankle. I chatted with the lady, then went to report to the attending doctor, who generally did not focus on minor rashes. After several interruptions, I explained the case. He dismissed me to apply some cream and move the patient along. I mentioned a Grey's Anatomy episode about necrotizing fasciitis to highlight my concern. Necrotizing fasciitis is a serious disease caused by bacteria that move quickly under the skin and destroy tissue. The doctor laughed it off. When I returned to the patient, she was in significant pain, and the rash had spread far beyond the marked area. It was indeed necrotizing fasciitis. She was rushed to surgery, but the infection was too advanced. She lost her leg, but survived. I learned to always trust my instincts, even as a student. Story 37. As a resident, I had a 14-year-old patient I saw during a pediatrics rotation who had been treated by 3 different providers, first 2 female and 1 male, 2 third-year residents and 1 chief, for hematuria. The first provider did a dipstick, saw blood treated for a UTI with Keflex. Patient shows up 2 weeks later, same complaint, again dipstick with blood, now a course of Bactrim. Comes back again, same complaint, blood on dipstick. Third provider puts her on Levaquin. Plan is ID consult for IV antibiotics if not improved. I see her for the next visit, ask her if she's on her period. She says no. I ask her if she knows if she's bleeding from her vagina or from her urethra. She doesn't know what the difference is. I argue with the PEDS attending for 15 minutes that we need to do a vaginal exam to determine where the bleeding is coming from. PT was sexually active, was having penetrative intercourse with a partner regularly. Finally, attending gives in. If I get mom's and patient's approval, why the hell wouldn't I? Do the exam, sure enough, normal menses coming from the cervical OS. She was on depot for BC and had missed her shot, was having dysfunctional bleeding. Dosed her with depot, bleeding stopped, all was right with the world.